Hello, this webinar is being brought to you by the American College of Radiology, Commission on Radiation Oncology Education Committee, and the Council of Affiliated Regional Radiation Oncology Societies, CAROS. This is your host, Hina Saeed. I'm an assistant professor in the Department of Radiation Oncology at the Medical College of Wisconsin. The radiation oncology webinars are designed to keep residents, radiation oncologists, and others well informed about the constantly changing and emerging technologies, treatment techniques, best practices, and pertinent topics related to the field of radiation oncology. The goals of this specific webinar includes understanding the importance of basic communication skills, defining patient-centered communication and understand its impact on the patient experience, learn and apply frameworks for effective information sharing, and applying effective communication to patient interactions during the pandemic. Moving on, we are very lucky to have the panelists who are experts in the field of effective communication. Our first panelist is Dr. Kavita Dharmarajan. She's an associate professor at Mount Sinai Hospital in New York. Her research interests include serious illness communication, decision-making, palliative care, geriatric cancer, and incorporation of palliative care and geriatric principles into radiation oncology. Our second panelist is Dr. Joshua Jones. He's a radiation oncologist and palliative care physician at the University of Pennsylvania. His expertise is in the use of palliative radiotherapy, symptom management, complex communication for patients with advanced cancer. So let's dive in to see the presentation with Dr. Dharmarajan.
Hi everyone, my name is Kavita Dharmarajan. I'm an associate professor of radiation oncology and palliative medicine at Mount Sinai Hospital in New York, and it's my privilege to be able to talk with you today about basic communication skills for every and any interaction. I just want to start by talking a little bit about why we should bother spending time on learning communication or reviewing communication strategy. And it's really all about really improving patient care, improving team dynamics, having effective communication skills also helps physicians improve their self-care. Moreover, hospitals and insurance companies seem to like it a lot, and policymakers like it and pay attention to it. And this may look familiar to you, but if not, it is a survey that patients receive after they see providers or have interactions with providers. This is CGCAPS survey. So CGCAPS is the Clinician and Group Consumer Assessment of Healthcare Providers and Systems, and it's a standardized tool used to measure patients' perceptions of care provided by physicians in an office setting. And you'll see here, of the many questions that there are, almost a third of them are about how well the physician communicated in the encounter. Did they explain things in a way you could understand? Did they listen carefully? Did they give easy to understand instructions? Did they know about me as a patient? Did they show respect for me, for what I had to say? Did they spend enough time with me? So important to keep this in mind, that every patient that you end up interacting with may be filling this out about their interaction with you. So it's sort of a big deal. Effective patient-centered communication improves patient care, which I mentioned briefly, in several ways. One is it can actually improve diagnostic accuracy. This has been proven. In a Harvard Business Review, for instance, which I'll talk about on the next page, it's actually been associated with poor communication. Actually, has been associated with primary factor in medical errors. Patients are also more likely to follow your recommendations as a physician if you are able to communicate with them in an effective way. Safety is improved. Like I said, a third of adverse events are from miscommunication. Good communication improves patient and family satisfaction. It improves team satisfaction. It's really, as a radiation oncologist or any type of physician in general, it's really one of the most important skills that we can learn, we can teach ourselves, or we can hone as we continue our practice. So at this time, all medical schools are now required to teach some form of communication skills. ACGME is requiring residency programs to send progress reports on residents' communication. This is primarily happening in internal medicine programs, but it's seeping into radiation oncology as well, and other subspecial or other specialized fields. The Joint Commission has developed standards for hospitals and effective patient-centered communication, and HCAHPS, or the hospital version of CGCAHPS, provides feedback to hospitals on how well their physicians communicate. And the Institute of Medicine says we don't get enough teaching on. So with that, I just want us to start by reflecting for a moment on patient-centered communication and what does that look like when it's done well. If you can think of a time when you saw patient-centered communication gone well, what did it look like to you? What were the factors about it about that encounter that you witnessed that stuck with you? I'll just give you a moment. Okay. The Institute of Medicine has a definition of what is high-quality patient-centered communication, and that is a respecting and responding to patients' wants, needs, and preferences so that patients can make choices that are best aligned with their individual circumstances. And these things may include eliciting a patient's true wishes, recognizing and responding to emotions, providing information in a clear fashion, and listening to patients' concerns. So essentially, many of the same questions that patients receive in the CGCAHPS survey when they have seen a physician in a clinical encounter. So you might be thinking, I'm already good at communicating. Everyone says I'm great at it. I don't need to learn anything new. And there may be some of you who may be thinking, I really suck at this, and this is a good opportunity for me to learn how to get better. And to both types of people, I would say that good is the enemy of great. We are all probably at some level pretty good at this because of the field that we're in and the training that we've had up to this point and the practice that we've had in conducting what can be pretty difficult conversations with patients who are sick. And so the good news is that there's always a way to improve, to get better, to make it easier for us, and more meaningful for us as well as for the patients. And for those who think that they suck at it, the good news is that communication skills can be learned. People are not born with this. This is something that we have all learned, whether we remember how we learned it or not. These are all skills that are acquired. So I'd like to show you the graph, a scatter plot, that basically shows a patient-rated competence with communication plotted against a doctor self-rated competence with communication. So you can see there's really no correlation between what patients think in terms of how well their doctors communicate with them with what the same doctors think in terms of how well they communicate with patients. So except for this loner out here who, patients really think that he sucks and he or she believes that that's true too. And then the guy out here, or individual out here who believes that they are really damn good communicators, and then the physicians alike or the patients alike agree with that, there's really no correlation. And I would especially want to alert you to the folks down here who are really, patients believe they could really do better, and the physicians, however, have a different view. They believe they're already pretty good, like this guy out here. So how do we get better with communication? Well, it's really in the deliberate practice. We have to understand where it is that we are, making our differences, our improvements. Think deliberately and reflect deliberately about the various nuances and changes that we're making. In this book written by Jim Collins, Going from Good to Great, he says that there's a minimum of 10 years or 10,000 hours that you need in order in practicing a craft in order to become an expert. And that the goals of deliberate practice are improving your existing skills, extending the reach and range of your current skill set, and deliberate practice also involves going outside of your comfort zone. So these are all things which I'm hoping we can start doing today, and then you can take the skills that we learn together today during this webinar and practice them in clinic next time you see a patient. So the one way in which we can perform deliberate practice is by learning a set of communication frameworks. So these are frameworks that will provide a scaffolding that you can use on a daily basis. You'll get a terminology that you can use and you can share with other people who also know the same terminology, so that you can give and receive feedback on these named skills and can also be able to teach them. And you can improve your own communication skills through this form of deliberate practice. And also, this is kind of fun. You can practice these skills with your friends and loved ones, although be careful, they might catch on to what you're trying to do, and it might backfire, having spoken from personal experience. But it is fun, and it's a different skill set than what we typically think about learning in radiation oncology, and so you can have some fun with it. So by the end of this session, I'm hoping that you will be able to understand a communication framework called Ask, Tell, Ask, which helps us to share information effectively with patients and families. I'm hoping that we'll be able to recognize and respond to emotion with the NNURSE communication framework, which we'll go over what that means. And I'm hoping you'll be able to have a better idea about the various parts of communicating serious news with the SPIKES framework, which I'll also go over in detail. So we'll start by reviewing the skills for information sharing with the Ask, Tell, Ask framework. So the Ask, Tell, Ask framework is really an ask, which is an initial check-in or understanding the scope of information that a person might have before you dive in, to then tell or share the information, some medical information that the patient may need to know in order to help them make a decision, followed by a second ask, which is essentially an opportunity for you to check in with the patient and for the patient to be able to tell you what they understood, or rather whether they feel like they have a good understanding, and it provides key information about comprehension and coping that a patient might be experiencing right at that moment, and that will help you tailor what you need to say next. So one way that so I'm going to give you some examples of what you can say in each of these different pieces of this framework. So for the first ask, one way you can ask this is, tell me what you've heard so far. How do you like to receive information? Are you someone who wants details, or who likes to have the big picture. Is it okay if I share the results with you? So this is asking for permission to move on to the information sharing. We try to avoid asking questions like, tell me what your understanding is, or what do you understand? That that can be sometimes misconstrued as an aptitude test for patients who might be already quite overwhelmed. So the better way of asking is, tell me what you've heard, not what you understand, but tell me what you've heard so far. Then when you're doing the tell, it's important to share the information in a succinct and clear way without a lot of ands or buts or maybes, just the information. So for instance, one example of a tell in a patient who has a newly diagnosed pneumonia is, your CT scan shows pneumonia, an infection in the lungs. And then you can follow that up with, we are treating her or you with antibiotics and oxygen to help breathing. Then stop. Don't say any more. And then that silence is sometimes really difficult. We all want to fill the space with words, but it's really important to just stop and then wait for a response. You can say, for your next ask or the second ask, I just gave you a lot of information. Can you tell me what you heard? Or if it's you really did give them some even bad news potentially, that was a lot. How are you holding up with all of this? These are ways of really trying to stay aligned with where the patient is in their information processing at that moment in time, so that you're not getting overly ahead of them and they're not feeling left behind. Obviously, we will, especially in our field, there may be some bad news that's part of that tell. I'll go over that in more detail with the spikes framework, but when we are, giving information that may be overwhelming or anxiety provoking or scary, we're going to need to recognize that there's going to be some emotional reactions from the patients or family members as a result of that, and then we need to respond to it. So first of all, we need to recognize that emotions can happen at any time. And sometimes you might not be able to actually see the emotion the way that you can on a child's face, for instance, who is unfiltered. But if you sense it, you have to address it. Otherwise, the patient and family may not hear anything else you have to say. Without acknowledging the emotions, you might not be able to move the conversation along. And that's really, I think, where a lot of us feel sometimes frustrated or stuck. We feel like we're saying the same thing over and over again with patients and families, and they're, how many times have you heard it? They're just not getting it, or we might hear others say that. And this is, I think, where a lot of times we lose patients and families, is because they may be having an emotional reaction and we're not addressing it. We're not offering support for that point, and thus they're not able to comprehend what's the next step or what's the consequence. And I'll give you a case of this. This is an actual qualitative interview that was conducted during Dr. Tulsky, who is the chair of palliative care at Dana-Farber, during a preliminary study that supported an R01 on communication skills in medical oncology fellows. And he interviewed a 38-year-old woman with AML who had a pre-visit estimate of cure, which is of 90 to 100%. That was her pre-visit estimate of cure. So he interviewed her after after her visit with her oncologist, and the oncologist's prognostic discussion with her was also audio taped. During the audio tape discussion, and this was a discussion specifically to share prognostic information, the oncologist said, so if you had 100 people, the survival curve drops down because people die of one thing or another, including relapse. That tends to level off at about 2.5 years after transplant and stays level after that. It's about 30% in your situation. We have a few options for treatment. Let's talk about the possibility of a stem cell transplant and possibility of cure. So that was a lot. What do you think the patient heard? Let's see. So 2 weeks later, she was interviewed again for her post-visit qualitative interview. And during that visit, she believed that her post-visit estimate of cure, she stated, was again 90 to 100%. Now, is that what the oncologist said during that prognostic discussion? I don't think so. But this is what the patient told her interviewer. She said, after he, the oncologist, said the 30%, he just kept dinging along in his facts, and I was stunned. Literally, my note-taking was completely done. All I wrote was 30% the rest of the time all over my paper, and I mean, I just couldn't get past that point. I don't know how to describe it. And thus, her post-visit estimate of cure remained at 90 to 100% because she did not process the information. She heard it, but she didn't process it. And so this is a very clear example of how strong emotions can hijack a person's cognition, a person's ability to process, to understand medical information. And it's important to know that emotional data that patients might give you because of a look or because of a behavior or because of something they might say is independent of cognitive data. It's independent of the actual medical information that you're trying to share or that you're thinking that they heard. And they can actually conflict with one another. Emotional data can conflict with cognitive data in that emotions can actually derail cognitive processing and understanding. Emotional data helps us to know how much information we can cover, how much understanding has occurred, and how fast we can go with continuing our discussion with the patient. So we have to be able to assess or get emotional feedback from the patients and know what to do with it. So the first step is to recognize it. You can see in this picture that there's a lot going on here in this picture, but the main thing I wanted to point out to you is that nobody is looking at anyone else, and there's clearly, an emotional reaction happening here. I think she's, holding back tears. This is, mom, I think, who's trying to get some note-taking paper out so she can write notes. And there's no way that this clinician is going to be able to recognize what's going on in this, behind her, because she's not even looking. So the first step is to recognize that there is some emotion happening. And then you have to track it and you have to respond to it. Emotions are dynamic, they change rather quickly sometimes, and it's important to respond to them before you can move on, as I just explained. Rules for responding to emotion, the framework that we have that has been used for a long time now, is called NURSE, and each of these letters stands for a particular type of empathic statement that one can make. So the N in name is for naming, which is like to name the emotion or just to say something along the lines of, this is a frustrating situation. The U is for understand. I can't imagine what it's like to receive this news. Understanding what the emotion or what a patient might be thinking right now. But not to say I can imagine, because you actually can't imagine what it's like to receive some news. So you can really only say and honestly say, I can't imagine what it's like. I can only imagine what it's like. Respect. I'm impressed at how dedicated you are to your mom's care. S is support. We will be here for you. Here's a number where you can reach us. You're not alone. We'll be here with you through this. E is for explore. Tell me more about what you're thinking when you ask that. Never make an assumption that someone is thinking one way or another. If you're not really sure what to say, you're not really sure what the emotion is that they're experiencing, you're not really sure how to respond, you can just say, can you tell me more about what's going on in your mind right now? I've said a lot. Can you tell me a little bit more about what you're thinking? Silence, finally, is the second S, and that really allows people the opportunity to say what's on their mind. It's really hard for us to actually give enough silence. Palliative care physicians are really great at this. They will just keep silent for like what sounds to me like an eternity, but it really does open the floor for patients to be able to say what's on their mind, and sometimes very surprised about what comes out of their mouths next. And so I have often used silence, and I tap my foot or the toe in my shoe like 10 times, or I say 10 Mississippis, 1 Mississippi, 2 Mississippi, 3 Mississippi, 10 times to make sure that I'm at least giving about 15 to 20 seconds of silence and even that may not be enough, but that's what I can do, and so that's what I've been practicing since I learned this technique. Exploring the patient's world with the E for explore, tell me more, can really get you a lot of information about what's going on in that person's mind right at that moment, and can help you tailor what to say next. And you can say it in a number of different ways. For instance, I'm just meeting you for the first time. Can you tell me a little bit more about yourself? That's a really big open question. You might not have time to hear everything. But sometimes it's an important first step in order to establish a rapport with the person. Or you could say something like, I'm just meeting your father for the first time. Can you tell me more about him as a person? Or you can ask specifically, can you tell me a little bit more about this particular thing? Can you tell me a little bit more about, this, about why you are wondering about this, or something along those lines. And then finally, we have the last the SPIKES framework, skills for communicating serious. So what is difficult about communicating serious news, and where do we get stuck? I'll just give you a moment to kind of think about that for a sec. Well, so oftentimes we're worried about provoking an emotional reaction, but now you know how to respond to emotion because we just went over that. What if the patient starts crying, or what if I'm taking away all of their hope? We don't want to have the responsibility of taking away anybody's hope. God forbid. We are really afraid of destroying hope. Or what if we have some guilt? What if we feel like we should have ordered that scan to occur sooner? What if I should have found that cancer sooner? So these are reasons why serious news is not always presented in a very clear, sort of categorical fact to have half-truths and misinformation. They don't want. Who does? But what they have been surveyed multiple times at this point, and they always tell us that most of the time they almost always want direct, truthful information. But most would like the provider to check in with them first regarding how they prefer to receive the information. And most individuals wish to have a loved one present during the discussion. And so it's important to, ask patients, do you want to, if you know you're going to be providing some information that might be difficult to bear, do you want to have anyone here with you, or is there anyone else that we could get on the line? Now that we're doing a lot of telehealth, it's actually pretty easy to get someone else on the line to listen as well for that, support. And it's important to also know that hope does not go away. So this is a study that was published by Dr. Smith from Hopkins in oncology in 2010, so that's a decade ago now, that giving honest information to patients with cancer actually maintains hope. This is the HERTH Hope Index, which is a index of patients' hope before and after they receive honest information about their prognosis. And these are patients with fairly limited disease, limited prognoses. They all have incurable advanced cancer. And you can see their hope before and their level of hope after is essentially unchanged. If anything, they have more hope after, slightly, probably not statistically significant. But it's really, really important to keep in mind that we are not responsible for destroying patients' hope. This is an inherent characteristic to patients and families. We cannot modify that, no matter what we say. So by the end of this portion, I'd like you to be able to use a communication framework called SPIKES to deliver. So SPIKES is a talking map, just like NNURSE was a talking map for showing empathy, and Ask, Tell, Ask was a talking map for giving information in a clear way and checking in afterwards. SPIKES is a talking map for delivering serious news. So S in the SPIKES is for setting up the conversation. This involves where you want to have the conversation, making sure you're in an appropriate place, not in the middle of a hallway, making sure you have the right people involved, asking if patients want to have a loved one. Perception, getting an understanding of what information patients already have, so you know how to start, so you know you can be on the same page when you begin the conversation. Asking an invitation to share the information, telling them the information, that's the knowledge piece, starting with a headline, expecting emotion and responding to empathy, summarizing and strategizing for the next steps. And what is this? Well, this all boils down to the same communication frameworks which I just shared with you. The ask, tell, ask. Perception and invitation are part of that first ask. Knowledge is the tell. Summarizing and strategizing is the second ask. And NNURSE, responding to empathy, responding to emotion with empathy. So just a few more pieces about each of the individual sections of this talking map. Setting, you want to, like I talked about, you want to talk about what facts you want to share, what players you want to be there, the atmosphere, making sure you yourself are ready. And sometimes if there are multiple people, this is, specifically in regard to if there's going to be a family meeting that takes place, you want to have a pre-meeting, make sure everybody's on the same page before you go in and present your information to the patient or the family. You want to negotiate roles, and you want to prime the task for learners. So if there are medical students or residents early in training who may be participating in this, you want to give them something to look out for with regard to the communication skill set that you're modeling. So perception, who to ask, how to ask, and then follow-up questions and clarify. You want to get a sense of the big picture for this patient. And so we talked about this, one way you ask, just so that we're all on the same page. What have you heard so far about the condition that your mother is in right now? Again, you want to avoid what's your understanding or other statements that can be misconstrued as aptitude questions. An invitation is the next step, and that's an important part of assessing readiness to continue the conversation. And if patients or families are not ready, they will not be able to hear the news, no matter how many times you tell it to them. So you must explore and address the other issues, usually emotion. There may be emotion first. And if they have anything other than a yes as their response, then you have to pause and reschedule that conversation for a different time, or figure out what it is that needs to take place in order for that person to get ready to say yes. Even if they're sad, they may say yes, and that's why you still have to ask. Invitations help pace the conversation, they're patient-centered, and they maximize time efficiency. You want to make sure your knowledge is given in a very clear and concise way. Sometimes people will start by saying something like unfortunately, or I wish I had better news, or I don't have good news. These are all examples of warning statements, and can really kind of prime a listener when you say something like that, so that then they you know, they have a little bit of a hint that they might be receiving some bad news next. Say your headline and then stop. Ideally, the headline should be a single sentence, big picture, avoid the medical jargon, and follow with silence. For instance, the CAT scan shows that your cancer has spread to your liver. Note, I did not mention that there are 3 spots in the liver. One of them might be something else. One of them was there previously but now has grown. No, it just says this one very clear statement, and then you can, once you know that that was heard, then you can qualify with the conversation in the next phase. The various different aspects of this news and the implications. After you say your news, or after you share the information, share the news, you're going to need to expect some emotional reaction. You want to remember your basic toolkit with the nurse statements. You can also use an I wish statement, because that, and an I wish statement is something like this: I wish I had better news, or I wish we had stronger antibiotics, or I wish we had a cure for this. I wish statements are a great way to express honesty and empathy, and it helps you, to align in an empathic way with patients, because you want what they want, right? You can't give them that because it doesn't exist, but it's okay for you to share, and it's actually good for you to share that you wanted what they want, that you're aligned with them in their optimism, and remember not to put any buts after, so just say, I wish we had a cure for this, period. Not, I wish we had a cure for this, but we don't. Common pitfalls to keep in mind are mistaking an emotional reaction for a cognitive question. For instance, if someone says, there must be another line of chemo we could try, or can we just, like I was moving during the MRI, like can we just repeat it again? These are ways that patients might be expressing their anxiety or fear, though they may be asking what sounds to be a cognitive question. And so you can't answer their cognitive question before you actually answer their emotional, before you respond to their emotional reaction. Responding to distress with a treatment will not be beneficial. So if someone says, can we just repeat the test? One thing you could say is, I know this isn't the news that you wanted to hear today. Or, I wish I had better news. Or, I can only imagine how scary it must be to think that the cancer might be back. Or something along those lines. Remember your nurse, and I put it here again on a new slide, same words. This really does go a long way, as an avenue to express empathy for patients who are going through a hard time. And finally, summarize and strategize. Beware of the pull toward the second S. Our own discomfort or agenda may push us prematurely to discussing this strategy, and we have to be very mindful of that. And then just check in before you move on. If you ever feel like you're, feeling like you're getting to the summarizing, strategizing portion of a consultation or a clinical encounter, check in before you move on. I know I was saying a lot. Would it be helpful to talk about next steps, or should we take a break here? And if the answer is anything except for yes, then you have to stop, respond to emotion, and then try to move on again. And the, really important to keep in mind that the core skill in elucidating goals of care, or patients' preferences or their priorities, which can be especially helpful when we're discussing palliative radiation with patients, is really exploring the patient's, values, goals, preferences, priorities, and really the way that you do that is by constantly going back to the well. given the situation, what is most important to you? What else is important to you? When you think about the future, what concerns you? What are you worried about? When you think about the future, are there things that you want to do? Are there activities you want to do? Are there people that you want to see? Are there places that you want to go? Um, and always going back, even if you get an answer for each of these things, there's probably always something else there. And you want to try to get as much information as you can, because the more information that you have about what's important to patients, the better you can take care of them. So that concludes this didactic. I'll leave you with a reflection to just think about, and really 3 questions that I would like for you to think about having listened to this. 1 is, what surprised you about this didactic? 2 is, what will you take forward from today? And 3 is, what are you still wondering about? Thank you very much.
Thank you, Dr. Dharmarajan. That was a great presentation on communication, and certainly very important for not only our profession, but life in general. I would now like to open the floor for any questions during the live Q&A session. Please send your comments or questions regarding any challenges in communication you have faced to the chat or the QA feature. Let's start with the first one. So what are some of the barriers or challenges to effective communication?
So I can jump in here. And first of all, thank you so much, Kavita. This was a great presentation, and hopefully we can get a lot more discussion now. As I think about barriers, and as I think about when I teach my residents and when I teach our palliative care fellows and our oncology fellows communication skills, that there are a couple of different things. You know, one of the participants talked about also being aware of a pitfall, becoming defensive. And it's something that we all think about, and we all, you know, we want to do the best for our patients, and we all practice, and we have our spiels for what we're going to do for whole brain radiation, what we're going to do for this. But one of the pitfalls is that we aren't necessarily meeting the patients where they are at. And so that initial agenda of understanding what is important to you, what do you want to be discussing today, really understanding where patients and families are coming from becomes critically important. This is not a one-way conversation where we are providing information to them, but it's supposed to be a back and forth, an interactive discussion where we can think together about what's going to be best and how do we do that. And I think part of our challenge is that when we go in, we think that we know where patients and families are coming from. And it becomes very easy not to ask that, to do that initial ask that Kavita was talking about, to really understand where they're coming from, to meet them where they're at.
Dr. Dharmarajan, would you like to add something?
No, I think that was, I agree completely with Josh.
So next question here. How have these barriers to communication changed or evolved during the pandemic?
So I would say, for me personally, it's that piece about including loved ones in difficult conversations, or really in any conversations where there's treatment decision making at hand. The pandemic has made our ability to include people who are geographically distant much easier. And I really am leaning onto that a lot in my clinic by bringing in people over Zoom and on the phone. And I actually, it's become really like a very important part of my clinic.
I would add that it's much harder to read emotions like this.
True. Yeah.
That when we're dealing with masks and muffled voices, and when we don't have the visual cues, when we don't have, the body language. The other thing that sometimes we have is this, where it is much harder to get a sense of what's going on when you're doing telemedicine, and you don't have those in-person visual cues. So most of what I do when I am teaching communication skills to people at all different levels is thinking about how do we respond to the emotions, and how do we use that to further the conversation. It is much more challenging to respond to emotions when it's so much harder to read them.
True, I agree. So looking back, what other communication skills you could have tried to improve patient care?
I think for me, I can start. In my personal experience, in training, we didn't really have. I didn't know any of these frameworks. I learned them from listening and learning from my palliative care colleagues here at Mount Sinai. Um, I think that one of the key pieces for me was really the initial piece about asking where people are starting at, making sure that I'm starting at the same level where they are, because we are like really like real, tertiary specialists. Like, people have seen many different physicians before they come to see us, and there's a lot of information that they have or that they may not have. There's probably a lot of confusion, and people are at various different levels of their understanding about their illness. And so that piece about really trying hard not to make any assumptions and just asking people, so what have you heard? What have the other doctors told you about what you're gonna about what's going on? That to me has been like really was the first really groundbreaking skill that I really took forward as an attending.
I
Yeah.
would agree with the comment in the chat about allowing enough time to communicate. One of the barriers and one of the things that we need to think about is how do we allow for time? And what has been striking to me as I think about the way that I communicate and how that is different today than it was before learning a lot of these skills and before doing a lot of this teaching is that, I initially thought, oh, if I'm responding to the emotion, it's going to make the visit that much longer. In reality, it actually improves efficiency because you are able to meet people where they're at. You're able to understand and hear what is on their mind, and that they then are able to help us to move forward in the conversation. And so those simple nurse statements that Kavitha was talking about can be amazingly effective, even at thinking about keeping our clinics running smoothly and keeping things moving in the way that we want them to.
Mm-hmm. Okay. So what changes or adaptations were implemented at your institution to improve communication with patients during the pandemic? Dr. Dharmarajan.
I think I said it. I think initially it was really hard, when there's so many more visitation restrictions, so people couldn't have people have their friends or family members come in with them when we were seeing them in person. So that really being able to do the visits over telehealth, yes, it does limit our ability to really read emotions, but at the same time, it also expands our ability to include more key people in important conversations. I don't know, Josh, if you have anything else to add for that. So just our ability to, and our department's permission for us to be able to do that more often has been really helpful for me.
I would agree. It's been remarkable to me how having a setup where we can have multiple people on the same telemedicine visit has been incredibly helpful. Where I've had visits where somebody might have been there alone in the past. Now they have their son in California, their daughter in Minnesota, and somebody else who aren't necessarily physically proximally close to them. We're able to include those individuals in the conversation. Is that there is much more attention to keeping patients and families updated. So when I'm seeing inpatients, that there are very specific ways that teams are actually updating on a very regular basis family members who are not able to be there in person. And so there's much more attentiveness to that communication with others.
I'm very glad, Dr. Jones, you brought up that point of talking to multiple family members. So what are the changes you have seen in communication in the context of telemedicine? This is probably one of them too, right?
Oh, absolutely. So again, to me, part of it is being able to ask that question and being able to get the right individuals in the conversation from the beginning. And while it is more challenging to read some of the body language and some of the emotions over telemedicine, it's also I find incredibly helpful to be able to have the right people there. My hope is that there will continue to be opportunities to have telemedicine visits, but I'm also hopeful that it's not only going to be telemedicine. I had to deliver some bad news about cancer that had returned earlier today, and it was really striking to me that the patient over telemedicine looked at me and said, I really just want to be there in the office with you. And so we set up a visit, and she's going to come back, and we're going to talk, and we're going to think through next steps, and we're going to do it in person. So I still think that there is tremendous power in being in the same room with individuals. I'm hopeful that at some point we will be able to have a little bit more of the physical connection. Another patient today looked at me and said, it is, as he put his elbow up to sort of tap my elbow as he was leaving, saying, it is still so frustrating to me that I can't shake your hand. So my hope is that we will have, coming out of this, an amalgamation where we can still use telemedicine when it is helpful, where we can still really fit more with individual schedules, where people don't have to take half a day to come into a clinic visit, where we can get the right people in the room, but that for those really emotional conversations, when we really are thinking about really complex issues, that we can have people in person and we can be there and experience these things together. I think that's really important.
So no, that was very good. I feel like the pandemic has taught us so many things. So looking forward, what are some changes in communicating with patients during the pandemic that you think will continue to be helpful beyond the pandemic?
I think these communication skills are really sort of classic ones. They are so important whether there's a pandemic or not. And I think, the pandemic sort of makes us value them differently, and maybe more in some settings. But I think that, hopefully one day soon there won't be a pandemic anymore, and we should still continue to use these same communication skills, and then be thankful that we were able to use them in person more regularly.
The other piece that I would add to that is it's been really remarkable to me how much more acceptable it is to think about advanced care planning. That because many people are worried about getting COVID and what is this going to mean, and my family can't be there with me, and how do I manage that? That I have found that many patients are more open to thinking about what the future might hold and what is important to them if they were to become sicker. And so our institution has spent a lot of time thinking about how do we do advanced care planning in the context of the pandemic. And I'm hopeful that sort of openness will continue, and that we will have many more opportunities to think about what's really important.
So moving beyond the patients now, to talk about our own team members, our own colleagues, how do you optimize this team functioning during the pandemic or similar crisis? And what are some changes in communication that you have noted during the pandemic, and what do you think will carry on forward?
So to me, it was really interesting how much of an impact not all being together in the same place had on the various different teams that I worked on functioning. Really just being able to be together in chart rounds, and to be able to run cases by each other, and to see people in person, and to just say, hey, can I check in with you about this really complex case that I have? What I found is that we have to seek each other out more. And we have to be more deliberate in the ways that we are communicating with people, where something that might have been a funny comment or an offhand remark, now when you don't actually see people, can sometimes be taken out of context. And so I think we need to be very deliberate in the way that we are thinking about reaching out to each other, supporting each other, taking care of each other, and making sure that we're communicating well. And my team, we actually have weekly check-ins, we have huddles, we've done all kinds of things, and we've really made it a point to try to have everybody's camera on as much as possible, so that we can see each other, so that we can interact with each other. And there have been tremendous benefits being able to do that, but we've had to be very deliberate in the way that we are approaching these things.
Yeah, and I would just add, we are still busy despite pandemic and everything else. That it can be easier sometimes to just have, just send emails back and forth, but I can't stress how important it is to sometimes just pick up the phone. And whereas you might have, come across the person that you needed to speak to in the hallway, and we're not doing that as much anymore and speaking to them in person, still the next best thing is to pick up the phone and talk to them over the phone rather than have things go back and forth in emails.
Mm-hmm. So, and the next question that I have is in general, like other than the pandemic. So what advice do you have for physicians in effectively communicating with other physicians in general? Like the people you meet at the tumor board or in a multidisciplinary setting?
I think a lot of the skills that you heard about in the webinar can be utilized with colleagues as well. And I mean, you don't think about them as skills. You're not, vital talking your colleagues per se, but these are basically ways that you can show respect for your colleagues and show that you are hearing them and you want to understand what they think about their patient and how you can best help them. So, I will often be asking my colleagues, so tell me what you're hoping for out of, when you're sending this person to me with a bazillion brain mets and they're not really, they're not doing that great. Tell me what it is that you're really hoping to achieve. And let's see how I can help you do that.
Dr. Jones, would you like to add something to it?
Yeah, so I agree. I think that using these skills can be helpful in any context. I'm actually shocked that my children have not yet interrupted using these skills with my children can be amazingly helpful too. The nurse statements, the wish statements and hope statements. I'm caring for an unfortunate 26-year-old woman with metastatic breast cancer. Leptomeningeal disease is awful. And in talking with a medical oncologist, she's saying, I'm really hoping we can get her to the next chemotherapy. And my response was, I hope for that too. And then we explored it more, but again, it's not but I'm worried. Because I am worried, she's worried. But it's how do you meet people with where they're at? And we all want to be optimistic. We all want to do what's best for our patients. But asking those questions, as Kavitha described, hearing the emotions as our colleagues are struggling and responding to those can be amazingly helpful. And Kavitha, your point during the presentation about sometimes you can get in trouble using it with your family and with friends. It's not uncommon for people to look at me and say, hey, Josh, are you palliating me? And the answer is probably.
I get that from my husband a lot. Don't you vital talk me. I know what you're doing.
So thank you so much, Dr. Jones and Dr. Dharmaraj. That was amazing. We really learned a lot from it. So that leads us to the end of the webinar. I would like to thank everyone, including our panelists and the ACR staff, the Commission on Radiation Oncology Education Committee, as well as our CAROs. I would also like to thank our chair, Dr. Joyne Liu, and as well as a past chair, Dr. Simon Loh. And I would also like to thank Trina and Teresa, who were phenomenal in getting all of this together, as well as Adina Wong, who's a resident who will be taking care of the webinars with me in the future. So here are a few links. Please click onto the first one for ACR membership to find out more about the RAD-ONC part. Click onto that hub link. And for all of the recorded webinars, that is the third link. Any comments and feedback, you can leave those for me on the Twitter account. Thank you so much.